Hi, I'm Dr. Sophia Yen, CEO and co-founder of Pandia Health. At Pandia Health, we believe that education and access to accurate information is key to women's health. And that's why we hosted 2 community screenings of M-Factor 2, which is a perimenopause documentary, followed by expert panels, which included experts in women's health, technology, and public policy. Perimenopause affects millions, and yet so many go through it without any information or knowledge, or proper medical care. At Pandia, our goal is to provide expert care for birth control and peri/menopause wherever you have internet and a mailbox. In this video, we've pulled together highlights from the expert panel, and we hope that you can enjoy this and share this with others.
Hi everyone, I'm Charlene. I'm the CEO and co-founder of Ember AI. We, unlike all these amazing people here, we're not in the provider policy space, we're in the finance space. We help make sure providers get paid. We work on revenue cycle management, so everything from denial appeals, medical coding, contract, like all the messy paperwork you don't want to see, that's what our team specializes in ultimately. So before we dive in, let's do the intro first.
Thank you. Hi, I know some of you in the audience. I'm Parman. I'm an OBGYN physician, and I've been practicing for a little over 20 years. 17 plus of those have been here in the Bay Area, and about a year ago I resigned from my full-time practice as I'd been consulting for startups that innovate in women's health on the side, and so now I do that 90% of the time and only 10% clinical. So I work with a company called UVA, and we're tracking hormones longitudinally over time to try and help us have a better understanding and have more actionable care that we can give around our hormones.
Awesome microphone. I am Tanya Goodrich. I'm a doctor of physical therapy, and I specialize in the pelvis and also bone health. And I have been a pelvic physical therapist now for over 16 years, and I started Healthy Pelvis Physical Therapy, and now we have 3 practices in the Bay Area. And I like to joke that we treat TMI, so if it's TMI, we probably treat it. And I like to say that as soon as I enter a room, it becomes a safe space. So feel free to ask any and all questions, and I promise it really kind of breaks the room, and we can talk about all the things. So I really look forward to, we're gonna get right into it with all kinds of TMI tonight.
So let's start, since we just watched the film, while the memory is fresh, what struck you the most about the film?
Well, I can start because this is actually the second time that I saw this. We got to do the same panel just a couple nights ago in San Francisco, so I'm feeling it's actually so dense of such information that it was actually really helpful to see again, because I feel like there were so many statistics and so much thrown out there that it was almost overwhelming, but also just incredible. I'm really excited to see so much of the kind of the stigma and shame kind of broken down and people really being able to talk about it. I get a little emotional and sad thinking about our moms and our grandmothers who really had to suffer, and I really hope that this is sort of the last generation where we really get to talk about all of this, and I'm looking forward to the future and feeling really optimistic and hopeful that our daughters are going to have way better care than we have. So that's my take.
Certainly, I was really, I learned a lot, and it was also, it jarred a lot of memories of my experience and the information that I received back 10 years ago, but to also see like that the whole hormone replacement therapy was still kind of being debated, I think, back then, and to now have more definitive answers is, I think, just very encouraging. And I was thinking about my mother's generation, and she grew up like in post-war Japan, so even more, not as much information back then. And I remember her suffering through things that she didn't really know what they were, and watching her too, I was wondering, well, what's going on there? So to have that information now, and then for my daughters to have even more of that, it's very empowering to be able to talk about this out in the open, because certainly that wasn't something that I think growing up we had that opportunity to do.
Is this on?
Yeah.
I had two subtle that's really interesting or nice to hear from someone else. The first was just listening to the husband and wife conversation and how she was sad and tearful. And it made me think I felt a little embarrassed to be going through this menopausal transition. In fact, my best friends are all OB-GYNs, so I have pretty much access to any of the hormone therapy that I want. I just need to speak up, right? And I remember hiding from, I was putting my patch on, my estradiol patch, and my husband saw me and he was like, "What are you doing?" And I was pretty shy about it. I was like, if I'm an OB-GYN and I feel a little embarrassed about this, what does everyone else think? Because we talk vaginas at the dinner table, right? So, my poor husband. But yeah, so that was one. I was that it's just nice to hear other women experiencing sometimes this feeling of embarrassment or shame or this getting old kind of thing. The other was I was also in residency when that Women's Health Initiative came out. So that was 2002, and I was a second-year resident, and we all got called into this one big conference room, and it was kind of this call to action of all right, we're stopping hormone therapy for all of our menopausal patients. What does that look like, and how are we going to accomplish that? And just seeing the fallout of that, and then having practiced since then over the last 20 years, and it really has been just creeping back, and it's been slowly okay to use hormone therapy, and now it's screaming at us we should at least consider it. It's not for everyone, but it should at least be a choice for everyone.
I would say that I was touched by the men's group. I thought it was really cute, and how they're like, thank goodness it wasn't me, but I was like, but it is also you. My daughter loves to say, ¿por qué no los dos? And I was like, yeah, ¿por qué no los dos? Es los dos. Es no solo mí, es tú también. And so it takes two to tango, and as people with uteri, we're sometimes the sandwich generation. We have, our elderly parents to deal with, we have our teenagers, and I absolutely sympathize with our partners who are stuck between two very hormonal people. The trauma of a 16-year-old in the house, and the drama of a peri/menopausal 52, 53-year-old in the house. So I want to acknowledge my husband who's in the audience. Other allies in the room, thank you so much for being here. But there is so much in this movie to take in, and I love statistics, to add another statistic. So with the WHI study, it was an increase, there's relative risk and then there's absolute risk. And so you can be like, that's a 7-fold increase. And it went from 1 out of 10,000 to 8 out of 10,000. But flip that, 9,992 people would benefit, and 8 out of 10,000 would get cancer. But even then, we're so good at breast cancer that most people don't die from breast cancer. And so that fear of breast cancer totally took it from 30% of people having HRT down to, you saw the statistic, now it's 3% of people. And exactly as you all said, 2 decades of women were deprived of estrogen, and I've seen the effect in my family with osteoporosis and with recurrent urinary tract infection resulting in neurosepsis and heart disease and maybe even a little dementia. So I'm glad that we're learning more. I'm sad that the current administration doesn't fund science and has totally cut our NIH, and we may be losing all of our researchers, but hopefully we will have more people to believe in science and investing in women and having more research about all of this. But the key is don't be afraid and make sure that you get help from expert doctors. And so my 2 points, just because I have to throw them out because I love talking and Susanna's laughing at me, is that one way to test your provider if they know the latest and greatest is how long can I stay on HRT? And if they're like 10 years, wrong answer. It's a risk-benefit ratio, it's shared decision-making, and for a lot of us Menopause Society certified practitioners, we say you're gonna have to pry this out of my dead hands or you're gonna find this patch on my body. And the way I look at it is biologically. Your body takes away your estrogen at around 52. You've had babies, you've stayed around a grandmother and give to society. And it's like, thank you for your service. Out to pasture you go. And when you take away the estrogen, all sorts of bad happens, and your arteries no longer dilate, your arteries fill with triglyceride, LDL, and the triglyceride is showing that you're insulin resistant, at risk for diabetes. And I was like, if all this badness happens, let's put back the estrogen. And the example I give is I went to my doctor, and 52-year-old woman on consistent birth control pills, so no hot flashes, no night sweats, because that was being treated without the fluctuation. But my waist disappeared, and my cholesterol shot up. And she put her hand on my shoulder, and she goes, you need to exercise and diet, and do better diet. And I was like, you don't know, lady, I'm an obesity expert at Stanford. People wait 6 months to see me. I tell people how to exercise. I tell people how to eat. Nothing has changed from last year to this year. And she's like, it's old age. And this was before I got into menopause. And I was like, okay. And then I got into menopause. And when I switched, thank goodness, my waist came back. Because I was like, oh my gosh, am I going to have to do GLP-1? Am I going to have to do metformin? But just putting the estrogen, because when you take away the estrogen, the fat goes exactly to your center. It more importantly goes to your heart and your liver. And as an obesity expert, I'm like, if it goes to your heart and your liver, you put that back because you do not heart attack. And we have fatty liver, which I call foie gras of your liver. Not a good thing. So, and then I don't remember the second one because menopause brain, but it will come back later.
So on top of that, both on the access policy and also like symptom side, how can we, everyone in the audience, know like we're getting the proper diagnosis from providers?
Yeah, I think that's a really great question, and it's still a tough one. Like, we don't have any single one test to say, aha, this is menopause or perimenopause. Kind of like they were saying in the show, we're putting it collectively together with age and symptoms. And the other important part is excluding and or including other conditions that might also be causing these symptoms. So many of these symptoms can overlap, and it doesn't have to be, you know, thyroid disease or you have perimenopause. You might have both, and many times these things can come in tandem, right? But it does need probably a series of lab tests, and as much as that can be a hormone panel, the hormone panel is probably not as helpful yet as it could be. Trying to make some progress on that, but also checking for other conditions that could mimic these same symptoms, because there can be perimenopause and you could have something else significant going on as well.
I love this question because I feel like so many pelvic issues have been normalized. I call them the mom pee jokes, where of course I leak. I have 3 kids. And it is a huge yellow flag on purpose. Yeah, yellow flag. Because none of us deserve to be in diapers. And that's kind of my mic drop moment, and it really gets people to think, because we don't have to suffer with just leaking. And it is totally treatable. And so what we worry about is that, I mean, the most common thing that we're seeing in the clinic is leaking with cough, laughing, and sneezing, right? And it's actually pretty darn easy to treat, especially when we do it early on, especially just even after having babies. And as we get older, because we have so many estrogen receptors that live down in the bladder, in the vulva, in the urethra tract, as soon as our estrogen starts to plummet, that whole area takes a hit. And so pain with intercourse is super common. I mean, this is what I'm treating on a daily basis, completely treatable. And we can even talk about, I don't know if now is the best time, but how I joke that every friend has one friend in every group that has to pee all the time. They know where all the bathrooms are. And a lot of people are like, that's me. And I want right now to kind of end that and learn how you can treat it. So basically, normal peeing is every 2 to 4 hours for at least 12 seconds long. And a lot of people say, that's crazy. I'm probably definitely only peeing for 6 seconds. And 6 seconds is a false alarm. And so basically, in our field, we call that jicking, which is just in case peeing. And that can totally get you into trouble. And the good news is that you can completely reverse jicking by knowing what normal is. And kind of a fun fact is that Alfred Hitchcock based his movies on the length of a bladder. So you should be able to sit through a movie and not have to get up. So from now on, since every friend has one in the friend group, you gotta tell them you need to be peeing for at least 12 seconds long. And I'm talking Mississippi's, like 1 Mississippi, 2 Mississippi. So you're gonna mark the time that you go to the bathroom, and then as soon as it starts to bug you, maybe in 45 minutes, you're gonna say, no, stop it. And you ignore it, and you move on. And I promise you're gonna retrain it, because you're gonna break that vicious cycle. Super interesting. So yeah, really, really, really good facts. So.
It's her.
It's her, it me, yeah, don't worry. I told you. You can text me and tell me how many seconds after this talk.
I just saw a 3-hour movie and that was like always on my mind. I'm not when to wake up. What part can I miss? But I think you mentioned policy and being I guess, a policy maker. And I mentioned in my intro that I'm on the Health and Hospital Committee for the board, and we're spending a lot of time talking about disaggregating data, so understanding all of the subgroups and women versus men, and then the racial groups and so forth. And I think that's very important for us to then really be able to start to pinpoint the right treatments, the making sure that we are tailoring healthcare to and trying to, as much as possible, customize it to the different subgroups. And the other thing too is that for us to make sure that we are, following cutting-edge advancements, technologies. We've actually been spending quite a bit of time on integrative care, and I have to say that I'm feeling or getting resistance. It's still not quite accepted, and it's something that I actually used during my chemo. I had neuropathy, so I went on acupuncture, and so I'm a big believer in that. But I guess what I realize is that it's a lived experience that is so important when we do our work in policy making, and I'm very grateful that it was a tough experience, but going through all that and having that lived experience that I can share, and then trying to relate that and implement that into policy so that we can then offer the proper care to our residents. So I would say that's the key, is that we can bring our lived experience and then make sure that we do tailor to the different, given especially our county with such diverse community, that we can focus on the different subgroups and offer the proper care for them.
I would say that, technically to diagnose perimenopause, your periods have to be off normal. So if they were every 35 days and they become closer or farther, deviate from its normal, then that is the beginning of perimenopause, along with all of these kinds of symptoms. And exactly as was said before, you don't want to check labs during perimenopause, because if you just get this, it could be here, it could be there, and you don't really know where it is. So it is really based on symptoms, and the current standard is to treat the symptoms. But as a person who went to MIT and who likes numbers, rather subjective rather than objective, I do believe that there will probably be an estrogen level that is optimal for your brain, that is optimal for your bone. And we are seeing studies that show if you have this level, then you have a decreased risk of osteoporosis. And again, I saw it in a family member who used to be my same height, and we recently took a picture, and she's 3 inches shorter. And I knew that she'd have spine issues, but I was like, oh, this is spinal compression. This is it in real action in this photo. And this could have been prevented if she had gotten estrogen, if we hadn't withheld it from 2 decades of women. So, and then to speak to the differences, I'm really proud that with Pandia Health, I wrote 3,000 birth control prescriptions. And coming from MIT Research at Stanford, and I couldn't just write them and see women suffer from side effects. And I was seeing people of Asian, Black, and Latino have a different side effect than Caucasian people. And I realized, oh yeah, everybody in medicine realizes medicine is based on a 70-kilo white man. That is all of medicine. And certainly not for birth control, but Caucasian female. And the way we're taught to write birth control is, this is your professor's favorite pill. Try this pill. If it doesn't work, have a backup. Good luck with that. And I love spreadsheets. So I took all 40 different spreadsheets and ranked them. Most likely make you bleed, least likely make you bleed. Most likely give you munchies, least likely give you munchies. Most likely give you zits, least likely give you zits. Fixed it for the side effect we are seeing in people of Asian, Black, and Latina. Changed it for, I'm adolescent medicine, so we're focused on bone health. We recommend 30 micrograms of estrogen until 30 years old, so make sure we threw that in. Then if they have acne, PCOS, and then customized it. I think for now we use race as a proxy for genetics, and as an Asian, I absolutely encourage you to desegregate, because South Asians have a horrible HDL, Japanese have an amazing HDL, and if you clump them together, it averages normal. Genetics will be the future. And based on your P450, then you get this drug. Based on your HDL, you get that drug. And just as an aside, for Asians, when we do statins, there's a Chinese level of statin and maybe a Japanese level compared to a Southeast Asian, because the Chinese are more likely to get cramps. So it's really important that when we do research, we separate that out. When we're doing AI, that everyone in the room is represented, particularly the women or those of us born with uteruses, and by different race and ethnicity, because as some people say, if you're not at the table, then you're on the menu. So if we're not making decisions, then we will be eaten or we will suffer. So make sure we are included in the AI, make sure we are segregated correctly, or the genetics will be huge.
Before we open up for audience question, I'll ask one last thing, but just the timing. Right? Perimenopause has been around for a while. Like now we're getting some attention, bringing in awareness. We're seeing the blood loss running change. We're seeing the current administration doing their own policy. I'd love to just hear more about what does this moment mean to you, and what do you see coming in the next few months?
Wow.
Or any time frame. Any time frame, if that makes sense.
That's a tough question. I mean, when I first heard you asking that question, I was thinking, like, were you going to ask, like, is there like this window of opportunity, right? Like, is there a best time to start hormone therapy? And I think we're still trying to dial that in better, but we are seeing more and more evidence that the declining estrogen levels in perimenopause have potentially all these other downstream effects. So I wouldn't always say like earlier is better, but as you're recognizing symptoms, it's important to have that discussion. So that was my reflection on the timing part. Yeah.
I have a good one for the timing for the next couple months, is that I would like every woman in this room, I'm going to pause for dramatic effect because it's very dramatic. Seriously, but osteoporosis is 100% preventable, which means nobody should be getting osteoporosis. Now, most women don't know this, and the truth is that 1 out of 2 women will get an osteoporotic fracture. That's half of us will have an osteoporotic fracture. That's huge. There's actually a group in the UK called Sticks and Stones, and they're trying to eradicate osteoporosis by 2044. It's amazing. That means it should not exist, like polio. Like, nobody should be getting osteoporosis. So, one of the most important things that we can do, Dr. Von der Wright talked about it in this thing, but as we know, we got a lot of things thrown at us. A DEXA scan, and I was just talking with Dr. Parman about this earlier. A DEXA scan is inexpensive. It is the gold standard for bone health, and the problem now is that because of insurance, women are not getting DEXA scans until 65 years old. Now, as we just learned, is that too late? Yeah. It's way too late. So it's inexpensive, and if you can't get it through insurance, it's only like $50 or 2 for $99. And I'm not kidding, it's awesome, body spec, and it'll tell you more than just your bone health. It'll give you stats on your visceral fat, on your lean muscle mass, and the coolest thing is that bones, I'm gonna get super nerdy but give you some fun facts. So bone is dynamic, it's constantly changing. So let's say you get your results back and you're kind of shocked, like, oh my God, my bone health isn't great. Well, guess what? You can make that go away. So osteoporosis is like the more extreme one, but before osteoporosis, you would be diagnosed with osteopenia, which means that your bones are on their way to osteoporosis. But guess what? You can reverse osteopenia. Isn't that so cool? You guys want to know how to reverse it? Yeah. So this is how. So you want to eat well, right? You don't have to just have milk anymore, dark leafy greens, so you want to get enough calcium in. And then you want to do 2 things for exercise. The first one is your bones need to be stressed, right? So you need to be jumping. And it can be just as simple as like jumping jacks. Even better if you want to just jump up and down off a curb. That's all you really need. And then the other thing you want to do is lift weights, because your muscles and bones communicate. Isn't that super cool? They like literally talk to each other. I think it's amazing. And the other cool thing about bones being dynamic is that basically every 10 years you rebuild a completely new skeleton. Isn't that amazing? This is so cool. 10% of your bone gets remodeled every year, which means every 10 years you have a new skeleton, which I think is totally awesome and totally cool and also amazing because we can make changes. So if you do all those things and then also don't drink too much and don't smoke too much, I feel like the memo's out on that, but not enough on the positive things that you can do. Nobody in here is going to get osteoporosis. So to me, if nobody gets osteoporosis and no one's leaking, oh yeah, because guess what? Remember what I treat? Leaking, right? So guess who doesn't want to jump? Women that leak, right? Do you see how it all fits together? So health is really, it all comes together full circle. So that's what everyone in here can do in the next couple months. All right?
So I guess I'll get political since that's what I do. Having gone through the breast cancer, after coming out of that, I realized, and that happened, and I don't know why it happened. I went through the whole process of trying to understand, but I lived a very stressful, busy life at that time, and then going through the cancer, coming out of it, I realized, number one, things are important. What I do, I feel is important, but there's nothing more important than your own health and your life. And so just reminding myself every day of that, and waking up just being grateful for another day of getting to do what I get to do. I realize how fortunate we are, especially listening to all of you amazing women, physicians, and in the medical field, how lucky we are to be living where we are. And I know that we live in this bubble, and not the rest of the country is not this way. We have the best healthcare, I think, in the country, if not the world. And I think of that in that I had one of my firefighters, and I was a council member in Mountain View, who lived here, then retired and moved to Texas. And soon after, went through COVID and then was diagnosed with cancer. But we would talk about it, and he'd tell me what was going on based on my cancer experience. I had questions, and I just didn't get a sense that he was getting the best care and advice. And I told him at one point, I was like, I really wish you hadn't moved, because I think if you were here, you would have, and you would be alive today. So that really is always, just makes me very grateful that we're here. What can we do in this world, with what's going on at the federal government? I think, yes, number one, take care of yourself. I know that what's happening is weighing on so many of us heavily, and I talk with folks who are just really, depressed and worried and anxious, and so I can't stress enough how important it is to take care of yourself, and let's take care of each other. I think we're very fortunate again to live where we are, where we have a little different perspective on things, and I always say you have to be an optimist to do what I do in the political world, because if you weren't, you would just give up the next day. I've been in elected office for about 20 years now, and I've seen the ups and downs, and we've been through many crises before, and that's what I keep reminding myself and try to share with others, is that this is a point in time, and we'll get out of it. So let's just hold on tight and do everything we can. But we do have an election coming up in November, and an opportunity to change. And I apologize if you are supportive of our current government, but I have to say, as women, this is not right. This is not optimal for us, and we've had better. We can have better, and so we have an opportunity to change things. I think resistance, being out and voicing your opinion is really important, and I think that is starting to change the tide. So. That's what I would ask and suggest that we do is stay strong, take care of yourself, take care of each other, and let's make sure to keep speaking out.
Just wanted to say that we've been privileged at Pandia Health. We have a medical group that can prescribe in 14 states. And so I like to say we bring better than UCSF Stanford care to where we have internet and a mailbox, thanks to my birth control algorithm. And then our menopause physicians, we're a 100% physician team, and about 40% are Menopause Society certified practitioners. There's only about 4,100 Menopause Society certified practitioners in all of North America to serve the 2 million going into perimenopause, the 1 million going to menopause, and the 75 overall going after menopause as well. And certainly you don't have to be certified, but on the policy side, we're seeing movement to encourage at least 1 hour of education on menopause in medical school. So I just spoke to a student, I forget if it was UCSF or Stanford, menopause brain, and I was like, menopause is hot. So did they include it in your curriculum? And she's like, no. And I was like, that's not good. This is the top 2 medical schools around, and you all aren't teaching anything, crickets, about menopause. And as you've heard them say, and as I like to say, estrogen affects every cell, from your head to your toe. So whatever specialty, eye doctor, you get dry eyes. Bone doctor, you get bones and joints. Rheumatology, you get joints, heart, liver. GI, you've heard it. It affects every single cell. So would it kill you to have 1 hour on something that will affect 100% of 51% of this population? 70% will have a symptom that bothers them enough that they deserve and need care. 30% will get away scot-free. And we met a woman the other day, and we need to study her and clone her genetics. But the 70% of us that suffer, I think, deserve 1 hour in medical school. And then some people are saying maybe CME, continuing medical education. I get it. There's too much to do. But like 3 hours? If you didn't get it in residency, and maybe once every 10 years to do in menopause for internal medicine, family practice, and gynecology, I don't think is too much to ask. They just surveyed gynecology residents and residency programs, only 31% had a menopause curriculum. Flip that. 69% of gynecology residencies have no menopause curriculum for something that affects 50% of the population from age 52 until your last breath. So I think Governor Newsom shot it down. Maybe it was a money thing. Maybe doctors complained we didn't want any more CME. But I also thank nurses and everyone else. And I just want to say it's so impressive to see you in power fighting for women in health. I want to thank Director of Student Health here, Yugo Kawasaki, another Asian American woman, for hosting us here today and to committing the 2 schools that she's in charge of and giving them free access to birth control services. So it's very forward-thinking, and thanks to whatever foundation, she can tell us later, that is supporting that as well. So that's how I think we can make a difference. Some policies, some donations, and electing good people that believe in good policy.
And education, which is what we're
And
about.
education.
Well, let's take some questions, shall we? Who has a question? Does anybody have a question for these?
Does menopause end, or some people get used to it?
Yeah, that's a great question. There's some terminology here that I think can be confusing, and sometimes words are interchanged, but perimenopause is that transition from your reproductive years until your periods stop. The menopause itself is 1 day. It's the first day of your last menstrual period of your life, so that's like a finite point in time, and then technically then you're postmenopausal, but we still kind of call anything after that final period as menopause or menopausal, and then that perimenopausal transition on average they say lasts about 7 to 10 years. I think we're finding now that maybe there's an expanded amount of time that we haven't been capturing in that classic time zone there too. Does that answer your question?
Yeah, thank you.
I have a question for you about you were talking about osteoporosis. We work with seniors quite often, and you know, I think there's like the statistics, like 86% of people that have like an actual fracture from a fall. Only 50% of them come back home because it can be fatal, depending on, you know, they may fall and, you know, have a brain bleed or something like that. And you were talking about the osteopenia, is it? Okay. So is there an age in which that, like, they can no longer build that bone? Or is there a cutoff, I guess, essentially?
I know this, but I'm going to hand this to the physician.
Say my name.
I don't think there's an age at which you can't build back bone. We're like Tanya was saying, we're constantly, our bone cells are remodeling. We have osteoclasts that break them down. We have osteoblasts that build them up. So it's a constant like breakdown and rebuild cycle. So I think anyone at any age can rebuild bone, but it does get harder with age. The one thing that I kind of was thinking when you were talking about bone building is estrogen. If you're a good candidate for it, it only takes a very tiny dose of estrogen to also help improve your bone density. So it doesn't have to be sometimes the levels that it takes to resolve hot flashes or night sweats. So people that maybe are a little more hesitant about estrogen use, you can use a transdermal estrogen at a very low micro dosage and still get good bone benefits.
I had a question about clotting risks, because we see the study from 2002, and it talks about breast cancer and clotting risks, and then I feel like most of the messaging we're getting now is all about how that was not quite accurate around breast cancer risk. You know, speaking as a person who has 2 clotting factors, I'm always wanting to hear more about what the most recent science is around clotting.
I just happened to look that up the other night because I do some TikTok on perimenopause, and then people ask questions and they're like, "How do this for clotting disorders?" And so I did an internet search, but if you don't know, physicians have our own AI. It's called openevidence.ai, and it's limited to not just physicians, but anybody with an NPI. I don't know why they don't open up one to the public and one to providers, but anyway, if you have protein S or protein C, then yes, that is a definite consideration. But if you have, I forget the other one, then factor V Leiden, then if there's a family history, they don't recommend that you test for it. You just go ahead and treat, and it should be fine. But if you have it, then you definitely should be concerned with oral estrogen. The key is to know that the WHI study is very specific to conjugated equine estrogen. And some people still use that, but it's an oral one. But most of us have moved to transdermal. And so again, if you ask most menopause society certified practitioners what's on your body or what are you using, most of us are on the patch twice weekly. There's a once a week patch, but it's giant and thick. And so once you've tried the little one, you can't go back. But the transdermal, because you didn't eat it and it doesn't need to be processed by your liver twice or whatever before it gets active, it doesn't increase the clotting. By going through your liver's in charge of your clotting. And so by eating it, going through the liver, that increases your clotting factor. And they've shown in research the transdermal does not increase your clotting risk like the oral one does. But if you have 2 clotting factors, then as they mentioned, there are non-estrogen options out there. Everybody though can do vaginal estrogen because it's not absorbed in the whole body, and so it wouldn't affect any clotting. So that is still open. But there is paroxetine, there's the 2-fezolinetant, there's a linkuit. These are the horrible names. There's other drugs that you can try. And then, and so yes, for the clotting in general, know that Women's Health Initiative was a specific drug, conjugated equine estrogen, which is not estradiol, which people are calling bioidentical. But bioidentical is pretty much, there's FDA approved, FDA tested. They didn't mention pellets. We do not recommend pellets. We generally do not recommend compounding. I believe anyone who's trying to do compounding is just trying to make money off you because it costs more money, it's individualized, and it's going to expire faster. Generally, we can accommodate you with the different levels of FDA-approved, FDA-tested, bioidentical estradiol and micronized progesterone, which is also bioidentical, which they didn't use in that study. That's the other part of the breast cancer, is they actually analyzed the group that was only on the conjugated equine estrogen because they didn't have a uterus, so they didn't need the progesterone to block the effect of estrogen, increasing the risk of endometrial cancer. That group that didn't have a uterus, only had conjugated equine estrogen, had a decreased risk of breast cancer. And when they got breast cancer, they had a decreased risk of death from breast cancer. So now we feel that conjugated equine estrogen is not related to increasing your risk of breast cancer above baseline. And we now think it's the synthetic progesterone, medroxyprogesterone acetate, which pretty much nobody uses as much for HRT. That increases that risk of breast cancer.
Thank you, Dr. Yen. So just to confirm that the patch, it doesn't go on your arm, right?
Oh, it does not. So sorry. Yes, the patch groups.
She taught me that.
I'm used to the birth control patch. But part of it may also be testing. We've never tested on that.
Thank you for being here. I have a question. Do we know if there's an optimal level of estrogen? So if you go into menopause and your estrogen, I assume without any HRT would be at 0, what's the level that would need to be to maintain good bone health, mental health, and so on? And then my second question, because you said compounding is just a way to make money off of you. It's my understanding, is testosterone mostly compounding? I don't think, is there a non-compounding?
There's actually non-compounded testosterone. It comes in a gel, it comes in an injection. The gel, there's no FDA-approved testosterone for women. So we have to take the man testosterone, and it's a packet, and you suck it out in a syringe, and you take 1/10 of it, and you smear it on the place.
Compounding testosterone, so that was, sorry, I might have missed that, but thank you.
Yeah. But as to the level, the current standard of care, if you are basing it on the research that we have today and the national organization, the American College of Obstetricians and Gynecologists, the North American Menopause Society, now they rebranded themselves the Menopause Society, we treat to the symptoms and not to the level. But I think in the near future, we may have tests. And there are some research studies showing that if you have this level, we know from adolescent research, that if your estrogen's below 40, that's not good for your bone health. But that's adolescence. Adolescence is different from an old person. But a lot of people sometimes say, well, a 60-year-old, 70-year-old has this level of estrogen. I'm not trying to be a 60, 70-year-old. I'm trying to be a 40-year-old. We were supposed to be dead at 52. Everything else is gravy. And so if you want to function like a 40-year-old, we may need to get it for it. What's interesting is if we take out your ovaries before 50, we will give you 0.1 estrogen patch. But if you're 51, 52, we'll give you 0.025.
So right now, once you go into menopause,
There's no number that we're treating to. We're just treating to your symptoms.
Yes. Yeah, there isn't a standard range that's recommended, and the current standards of care recommend treating to symptoms. That doesn't mean that there's not times that we do test estradiol levels. Like sometimes somebody is on hormone therapy and you're just not getting the response. And some people absorb the medication differently, whether you're taking it orally or transdermally. So some people may not be as good of absorbers, and sometimes they need a little bit higher dose. Like right off the top of my head, I'm kind of thinking in that range of like 30 to 100 is kind of a common estradiol or estrogen range that we're checking on. But we don't have a goal of like this number should alleviate these symptoms. And to your osteoporosis or osteopenia question, I think there has been some data on a number, and I just don't know it off the top of my head.
I don't know, but that's the only one because that's the only.
And it only takes a little bit, you know, like we don't need those higher levels that can resolve the hot flashes and night sweats. The other thing is the problem with some of our serum testing, our blood testing, is that depending on the form of estrogen you might be on for hormone therapy, it is not all detectable in the blood as that. I'm trying to think of how I'm trying to say this, but when you do the blood test, it may not be detecting the level of that medication or what's being absorbed by your tissues would probably be the simple way to say that. So Hence why I'm jumping into working with companies that are really trying to innovate in this space and see if we can find target levels, better ways of testing these numbers, these ranges, and being able to create kind of an action range like we do our thyroid. Like we try and dial in that TSH to a certain range, right? We don't have that for our estrogens, our progesterones, that type of thing.
I would say with the urine test, I've been playing with it. And so the urine test, you do not want the Dutch test, which is dried urine test, because that has not been shown to be reproducible or as accurate. But these urine tests are like lab quality level little machines in your house or a photo color situation that won't just be plus minus pregnant, not pregnant, but actually corresponds with the level in your blood. And so if you can get the FSH, the LH, the FSH down, then that means that you've given enough estrogen that your body's not flogging your skin like, wait, I got some estrogen, give me estrogen. And so if you can get that down, then that's a good thing. But also, I was like, I have a family history of dementia, and if a little estrogen is good for brain fog, how about more? And I like jacked it up, and then I started getting headaches, and I was like, oh no. And then I like quickly peed and checked, and I was like, oh, that's a lot of estrogen. So then I like backed out. So it is like $250 for the machine, and then like $5 each time you pee on a stick, but it's kind of fun. So if you've got the money at the time, you can buy that.
Two more questions.
Those of you who are doctors and treating patients, what guidance do you usually give to your premenopausal patients, perimenopausal patients, menopausal patients in regards to supplementation, if any?
Yeah. I think they talked about some in the movie, which I really appreciated and liked. And I think at the heart of things, we can talk up and down about hormone therapy, but if we're not doing the fundamentals, we're still going to be very unhealthy, right? So I tend to think nutrition fundamentally probably even more than supplements, right? Like, so eating the rainbow of vegetables, fruits, nuts, and seeds, trying to get all your different colors in, because that's probably going to get most of these vitamins. I think that our omegas are a little bit tougher to get in, so those flax, walnuts, chia, probably, I think I'm hitting the biggies. Salmon, yeah, if you're not a vegetarian, salmon can be phenomenal there. Calcium and vitamin D are really important for bone health. You might have specific supplement recommendations for bone health.
Yeah, I would say the calcium and the B12 and the vitamin D, all critical for. And then actually, I've seen a lot of, and this is for the physicians as well, in the 90s when they talked about all the calcium that you want to chew, I heard that they are finding that not to be so great for your kidneys, for kidney stones. So something to look into, but I think in general, if you can eat it, just like Dr. Parman was saying, that's ideal. So really getting the full spectrum and then getting the labs tested for specifically the vitamin D and B12.
I would say on the calcium and vitamin D part, as a lactose intolerant person, and in a person of Asian descent, we as Asians do kind of approximate that. Like the Koreans and the Japanese all eat a ton of spinach. But you need to eat a ton of spinach. So we eat Costco level spinach, so we'll buy like 2 or 3 of those. I'm too lazy to wash it. The baby spinach thing. And so you stir fry it with some garlic, but you gotta eat this much spinach and like 2 or 3 times a day. Yeah. And so it's a lot of spinach. So that's why Asians are known for having bad bone, for having osteoporosis. And because of our lactose intolerance, and so they're like, oh, we'll have milk. And I was like, yeah, that's not happening. Oh, have yogurt. No, that's not happening either. I do ice cream because I love that, and pizza, but there are consequences. So what I tell my patients is, yes, if you can get it naturally, absolutely. All the leafy greens possible, but also bone soup. I realize with Asians, like, we have bones, and so it's actually leaching the calcium into the soup. And so this whole bone broth thing, there is a thing to that because of the calcium leaching. And then the Koreans also eat
tiny little fish, and they all have their bones in them. And so the kids love it as this crunchy kind of fish situation. And then like the tempura, even though I asked my nutritionist, and they're like, if it's tempura broccoli, don't eat it. I was like, but it's a vegetable. And he's like, no, it's deep fried. But maybe the tails, because they have calcium, and you're eating the tail. I just make fun of my daughter eating the tail, but that has calcium. But again, just with basic, if you have to do a supplement, I tell my patients, go to Costco. It's a white bottle with a red cap. I put it in the middle of our dining room table, and if you didn't have milk with your cereal or cheese or something, then you're taking a pill. And so 1,200 milligrams once a day in total of calcium, and 400 international units, or up to 1,000 a day. My endocrinologist friend gives her kids 2,000 to 4,000 a day. So, but also be aware, if you take too much vitamin D with calcium, this was one case that came up in our med school that my friend brilliantly picked up. There was an old lady, and she had kidney stones, psychic moans, and abdominal groans. If you can tell in medicine, we like to rhyme stuff. And she had hypercalcemia because she was taking a calcium with vitamin D supplement, because she's like, if 1 is good, 10 is better. And so she was taking way too many. So you can't overdose if you take too much calcium with vitamin D. So don't.
Great. We have one more question.
So what is the best way to ensure that your doctor is up to speed with all of this latest information? Is there a questionnaire that's out on the internet that you could use to, it's like if you go to a lawyer and you don't know anything about law, you don't know what to ask the lawyer can tell you anything, and you're going to say, yep, he's the expert, so, next thing you know, you're in jail.
Like I said, you can ask them, what is the layest treatment in menopause? And if they say the lowest amount of hormone for the shortest amount of time, and if you ask them, how long can I stay on this? And like 10 years. And the 10 years example I give is I give it to you for 10 years, and then when 10 years is up and I pull it away, what's going to happen? All the badness that if I had taken away 10 years ago, the bone density, the cardiac stuff, the brain stuff is all coming in, and so it just doesn't make biological sense. Your body does adapt, and you'll see Dr. Mosconi, I love her, she's like the goddess of brain and PhD and whatnot, but she admits in her thing that your brain goes down and then it recovers, but it doesn't recover completely. There's like 10% missing, and then there's like 30% of us who will never recover. So it's just something to know and something to keep a watch on, and that we'll get more data. But my thing is, by the time they get data, I'll have a heart attack, dementia, broken bones, and be dead. So I have to biohack until we get the data. So it will come in 10, 20 years for our daughters, but not necessarily for some of us here.
I was going to say too, another easy way might be if they're menopause certified. I want to put a disclaimer, there are so many physicians out there that are great menopause specialists that aren't menopause certified, but if you know nothing about your provider or that clinic group, you could look for somebody that's menopause certified. So it's a board certification you can do. It's kind of like a mini board certification.
You just take a test, and if you pass it, you get it. And I'm probably the only pediatrician you're going to be that's menopause society certified. But I was like, well, I'm going to run a menopause program, I'm going to know my stuff.
Thank you everyone for taking time out of your schedule to come and learn